We are really fortunate to have Antonia Carroll, who's agreed to come over from Sydney, and she's a neurologist as well as a neurophysiologist, clinical researcher, specific interest in amyloid neuropathies. And Robin, thank you for coming to talk to us about it.
Thank you very much. So, as you've heard, I'm a neurologist. I also do nerve conduction studies, so I'm a neurophysiologist. And I'm an active researcher looking at the early causes and early diagnostic strategies in amyloid neuropathies is what I'm doing my PhD on. So I work at St Vincent's Hospital in Sydney, but I'm also at the Westmead Amyloidosis Centre. So I'm going to first just start by setting the scene about what exactly is going on here in your nerves. So when you think about neurology, most people think about the brain and the spinal cord. So that's what we would call the central nervous system. But actually what gets predominantly affected in amyloid of all different types is this peripheral nervous system. So that's a nervous system that controls the cranial nerves, so how your eyes move, your facial sensation, your swallowing, but then also your peripheral nerves, so going out to your arms and to your legs. So when we think about the peripheral nervous system, you get a signal, say, from your brain going down your spinal cord to say that you want to move your hand. And then with this, I think that's the pointer, you get a signal that comes out, down through the peripheral nerve to the muscle here, and that's how you wave. Similarly, at the same time, if you get touched or if you touch a hot plate, you get a stimulation into the skin, which goes up through this peripheral nerve and into the spinal cord. And then that goes up to the brain, and then that's how we process our sensory information. But we also have the autonomic nervous system. So that's the nervous system that we've heard about a little bit that runs through a slightly different process. It still goes down through the spinal cord, but it's got a separate sympathetic chain, so they're not in the same kind of nerve channel pathways. And this controls all of the involuntary things that you don't really think about. So things like crying, saliva, how your gut moves, your erectile function, how your bladder works, all of those things can be affected in autonomic processes. And then there are also the small nerve fibres. So these are the little loose nerve fibres, like you can see here, that are in the skin, and that similarly travel with the sensory nerves up into the spinal cord. And they have a slightly different process. So when we actually look at a nerve itself, so this is a nerve. If you actually cut out a nerve specimen, this is kind of what it looks like. And you can see that there are lots of different fibres. So these round things are fibres, and that's what each of these little ones are here. And that each of these fibres carry different types of information. So you've got these larger ones with an insulating coating, which is the black, and they carry information about touch and pressure, but also vibration. And so often, if you're feeling dizzy and you close your eyes and you're not certain where your feet are in space, that's going to make you feel unsteady. So that's carried by those larger fibres there. And then these smaller fibres, and in particular these C fibres, carry information about pain and temperature, okay? And they're quite slow fibres. So what often happens, and why people often get a little bit confused about what's going on with neuropathy, is that often because your beta fibres are affected, you might not be able to feel. But then because your C fibre is affected, you often feel lots of neuropathic pain. So you get this funny combination of numbness, but also not being able to feel, and feeling sort of hypersensitive at the same time. And what we can see is that this is sort of a schematic of how fast nerve fibres are. So those bigger fibres, those A beta fibres, are a little bit slower than an aeroplane, but faster than a cheetah. Whereas those C fibres are slower than someone walking, which is why if you put your fingertip on a hot plate, for example, it takes a while for you to recognise that it's hot and need to pull away. So neuropathy means damage to the nerves of any cause. Okay? Lots and lots of different causes of neuropathy, vitamin deficiencies, B12. For example, lots of different things can do it. And there are two types of neuropathy. One can be that the electrical wire, this is the yellow bit of this nerve, can be affected. And that's what the yellow bit, that electrical wire, is called an axon. So sometimes if you're a neurologist, say you have an axonal neuropathy, that's what it means. It means damage to that electrical wire. But then there's also insulating coating that we saw that was the black of those nerves that are on some of those fibres, and that is called the myelin, or the myelin sheath. And that really just allows signals to be transmitted really quickly along the nerve, and sometimes you can get nerve neuropathies that affect that myelin sheath, and that's what we call a demyelinating neuropathy. So, in amyloid, we've heard on multiple different talks that you get deposits of these protein in multiple different organs. So in nerves specifically, you can get deposition in the peripheral and the autonomic nerves, and that can be in all layers of the nerve. You can also get it into the blood vessels supplying the nerve, therefore stopping blood flow to the nerve and causing a bit of ischemia or lack of blood flow, causing trouble with the nerves. You can also get deposition in ligaments and tendons, as we've been hearing with carpal tunnel syndrome and spinal canal stenosis, and then of course in other organs. And certainly some of those amyloid proteins can have a direct toxic effect on the nerves itself. Now, with the myelin that we were hearing about before, is that you usually get conduction down the nerves such as this, giving a fast conduction of information from one point to another. But often with these amyloid processes, it interferes with the way that the nerves are being able to transmit this information, and that's why you have impaired function and symptoms. Okay. So, when we actually have a look at that nerve, so this is a different specimen of nerve, stained with that Congo red that you've been hearing about at the moment. And you can see that this is a blood vessel inside the nerve, and it looks a bit thickened and a bit red. And similarly, here you've got sort of a big red, sort of blobby deposit. When you shine with polarized light, this shines up green, showing that that's that amyloidosis within that nerve. So often first goes into the blood vessels and then kind of spills out into the nerve itself. And so this is a normal nerve here showing lots and lots of these different sizes of fibres that we were showing on that close-up section before. But what happens as amyloid progresses is you can get loss of those nerve fibres, and that's what correlates with the symptoms that people get. Oi! Sorry, that just jumped about 20. I don't think that was me. All right, so in terms of pattern of nerve dysfunction in amyloid, there are lots of different patterns, 5 in particular. So the first is actually this mononeuropathy, so that means one nerve is affected. And the most common version of that is what we see with carpal tunnel syndrome. So what's important to know with carpal tunnel syndrome is that it's not directly a neuropathy per se, in that you're not actually getting deposition of the amyloid in the nerve itself. Instead, what happens, so the yellow here is the median nerve, so the median nerve is the one that comes through and causes the problem with carpal tunnel syndrome. And here you're getting deposition in the purple, which is what we call the transverse carpal ligament or the flexor retinaculum, and that puts downward compression onto the median nerve, causing symptoms. It occurs in over 50% of cases of amyloid. Often it's the presenting symptom, often 5 to 10 years prior to you getting any other symptoms of amyloid. And typically what people get is numbness in these fingers, so the blue fingers here, that wakes you up from sleep. Often you need to shake your hand, hang your hand over the side of the bed, worsened by doing things which causes either flexion of your wrist like this, so riding push bikes, jackhammering, or even at night time, often it gets worse because people sleep like this and you don't recognise that you do it. And that flexion causes trouble with the information getting through. So there are lots of things that we can do for this type of syndrome. So first is that you can, at night time, if you mainly get lots of your symptoms, you can use a splint like this to keep your wrist nice and flat at night. You can do physiotherapy exercises to try and get that nerve and the tendons moving a little bit more smoothly. You can have ergonomic alterations, so particularly if you're doing a lot of work where you're typing and things of the sort where your wrists are flexed, so you can change that position to make it a bit better. But often we need to go a little bit further because the deposition of the amyloid into the nerve itself, into the flexor, doesn't stop, okay, despite you doing those things. So often we need to do the local anesthetic and steroid injections, which is what you're seeing here. They can put a little local anesthetic and steroid to reduce any inflammation, or surgical management, which is quite commonly required. So you can have open surgery and you can have actually endoscopic surgery, so with a little camera, and they differ a little bit in terms of how quickly you can get back to using your hands. And this is a really good opportunity that we're trying to encourage our hand surgeon colleagues to send off samples when people are having it for this for histopathology in order to improve early diagnosis. So the second pattern of nerve dysfunction is what we call radiculopathy or plexopathy, and that's when the nerves at the level of the spinal canal are affected. And the most typical version of this is spinal canal stenosis. Okay, so again, this is not direct infiltration of the nerve itself, but it's direct infiltration of the spinal ligament at the back, the ligamentum flavum. And then that causes, again, like the carpal tunnel, compression on the nerves itself. Now, if you're, as you get older, often you've got a bit of osteoarthritis in the back, often you've got a little bit of disc bulges, and all of those combine to put extra pressure on those nerves. So typically, we make a diagnosis based on the typical history, and that is usually back pain that's lower lumbar, radiating pain through the buttock, down the side of the leg. With that, because the nerves up here are the ones that supply the nerves down here, you can get numbness on the sole of your feet, numbness up the side of your legs. And so it's important to be able to distinguish between that sort of numbness and actually true nerve involvement. And when we have a look at MRI scans, this is what we typically see. So you can see this is the bony process and the spinous process that you can feel at the back. And you can see that there is this thickened, this black bit V here is the thickened ligamentum flavum. We can actually measure that on MRI scan. So again, things that we can do, conservative management, such as neuropathic pain agents, and I'll talk more about those in a little bit. We can do CT or ultrasound guided steroid injections, which can often help to reduce inflammation and reduce pressure on those nerves. But again, often surgical management is required because the amyloid is still being deposited into that despite you reducing some inflammation. And again, histopathology is a great time for us to try and encourage our orthopaedic and our neurosurgical colleagues to try and send off specimens for that in order to improve early diagnosis. The third pattern is the small fibre neuropathy. So these are when the little C fibres, the ones that we were showing in the skin before, the loose fibres become affected. And so typically people get what we call a length-dependent neuropathy, or otherwise known as a glove and stocking neuropathy. And in this, so that's the typical pattern, but sometimes it can be a bit asymmetrical and patchy, which can sometimes be a little bit tricky. So you can get funny patterns or little patches around the body. And here you get insensitivity to temperature and pain, okay? You also get neuropathic burning pain, stabbing, shooting, prickly, cramping pains. Often you get something that we call allodynia or hypersensitivity, where things that shouldn't be painful become painful, like the touch of a sheet on your feet at night or the weight of a doona. Sometimes socks, sometimes shoes can be quite uncomfortable. Sometimes, even though the C fibres don't really have a role in light touch, sometimes you do feel numbness and tingling. And often this small fibre neuropathy goes along with the autonomic neuropathy. What's important to know about small fibre neuropathy is that when your neurologist or your GP examines you, your vibration sense, your proprioception, and sometimes even your light touch sensation can be completely normal. Your strength can be completely normal, your reflexes can be completely normal, and nerve conduction studies can be completely normal. And so often people feel a bit dismissed because they feel like nothing is wrong. And that can certainly lead to poor quality of life and sort of debility from that perspective, but it is a true thing, and there are ways that we can diagnose this, but it's often having the suspicion that this is what's going on is really important. The fourth pattern is that of autonomic neuropathy. So as we talked about, these are all the involuntary symptoms and involuntary actions in our body that you don't really think about. So really what becomes involved depends on which nerves are damaged and the severity of that damage, but the most common ones are dizziness on standing, nausea and vomiting after eating, and erectile dysfunction. But you can get a myriad of different things. So alternating constipation, diarrhea, feeling full really early with nausea and feeling like you're going to regurgitate or bloat after eating, poor bladder emptying and then frequent urinary tract infections because you've got urine sitting in your bladder, as well as incontinence can happen. Low blood pressure with dizziness when you stand up, fainting and having trouble exercising can be due to your autonomic nerve dysfunction or can be due to your cardiac dysfunction, as you heard earlier. Erectile dysfunction, vaginal dryness. You can have dry eyes and dry mouth, difficulty focusing near and far, say if you're driving and changing near and far, or difficulty adjusting to different lighting conditions. So if you go from dark space into a bright space, often it can take a little bit longer to adjust. Or you can have funny abnormal sweating patterns. So you can have no sweating, too much sweating, or even funny patches of sweating. And I guess the thing to say is that this is really, really common. So about 70% of people have blood pressure disturbances, 71% gastrointestinal, 70% of men have erectile dysfunction, lots of sweating changes in about 50%, genitourinary problems in about 40%, so that's more the bladder dysfunction, and then others that are eye changes and things of the sort. But they're really common symptoms in all different types of amyloidosis. And the last pattern is the pattern that we kind of tend to think of most commonly that we see with amyloidosis, which is the length-dependent club-and-stocking large fibre neuropathy. So that's when those bigger fibres with the myelin on them become affected. And this is a length-dependent process. So what it usually means is that it starts at the toes and comes back up and sort of spreads towards the knees. And around this time that the knees are involved, then it tends to involve the fingers, and that's just because they're about the same length. Okay, so it's a length-dependent process. And sometimes it can even involve the abdominal wall because these nerves come all the way around, so these are a length-dependent nerve as well. So usually when you have these sort of symptoms, you get touch, vibration and proprioception loss. And when I say proprioception, that's that sensation of where your feet are in space. You get weaknesses, loss of reflexes, and pain can often go along with this. And so while this is the most common type of large fibre neuropathy, there are a couple of funny groups that often get misdiagnosed, and often that's where people get a little bit of a delay in diagnosis. So sometimes people can get it starting in the upper limb without any involvement in the lower limb. That's not carpal tunnel. Often you can get what we call ataxia, which is unsteadiness of your feet or imbalance. Sometimes that can be because of the sensory fibres, but also it can be from involvement of the brain in one particular type of TTR genetic version. And you can also get a motor predominance, so without the sensory involvement. But all of those things often take a little bit longer to diagnose because they're a bit of a funny pattern and not the norm. So in terms of diagnosis, and this is slightly different order to what I had before, so this length-dependent neuropathy, the entrapment neuropathies and the radiculopathies are basically based on clinical examination, some questionnaires. We can do nerve conduction studies and EMG, and sometimes we can do nerve biopsies for that. And that's how we diagnose those groups. With these small fibre and autonomic neuropathies, often it's the clinical suspicion and the history that's most important. Postural blood pressures are really important, so often we'll do it lying down, standing up immediately, standing up at 1 minute, standing up at 3 minutes to get a good sense of what's going on. But we can also do nuclear medicine scans to see how quickly your gut's transiting. It can often be quite helpful. And then there are fancier things that can only be done at particular places where we can do quantitative sensory testing, heart rate and sweat assessments, and skin and organ biopsies, but often that's not really necessary in order to get to the diagnosis. Often you can make a diagnosis based on the clinical and your blood pressure alone. So when we think about the spectrum of amyloidosis, you've been hearing about lots of different types of amyloidosis. But the major types where you get nerve involvement are in ATTRv, or the mutations of ATTR, and in AL amyloid. And then there's a little bit less in these other different types of amyloid, including wild type. And I'll remind you, I think we just saw this sort of similar slide beforehand, is that even with ATTRv, so the mutant type, there are ones with predominant neurologic features that don't tend to have much cardiac, and there are some with predominant cardiac features without much neuropathy, and then there are a mixed bag. So it doesn't mean that everyone with the same mutant variant or a different mutant variant will have the same pattern as you. But when we actually look at these, so certainly for carpal tunnel syndrome, we see a lot of carpal tunnel syndrome in the ATTR with mutation, the hereditary form, and in wild type TTR, a little bit less in AL, but also in some of the acquired forms, so the rare dialysis associated. We see lumbar stenosis mainly in ATTRv and the wild type TTR with a less in AL. We see autonomic dysfunction mainly in the hereditary form and a little bit in the AA, or the one associated with chronic inflammation, as well as in AL. And the large fibre neuropathy tends to occur in the ATTRv more so than AL. We can see it a little bit in wild type TTR, and recently showed a couple of people with actually true nerve involvement with TTR, but it is pretty rare. And then a couple of these more rare types as well. And as we can see, there's also lots of other involvement. So particularly with ATTRv, you can get ocular manifestations, so you can get cataracts and deposition in the vitreous deposits, as well as vascular changes. Sometimes people get laryngeal changes, both in wild type and ATTRv, so that people notice a change in their voice that becomes what we call dysphonic, or changes a little bit in the quality of their voice. You can get trigger fingers as well, and that's actually from deposition in the joints, as well as the tendon ruptures. And then sometimes you can even get involvement of the muscles itself. And sometimes we can pick that up on DPD scans, which is an interesting new thing that we're looking at. So in terms of management, we've heard a lot about treating the underlying disease, so I'm not going to spend a lot of time on that. What I really wanted to talk to you about is more the supportive management of nerve problems, because certainly it's something that is pretty poorly done in many, many centres, and I think it's something that can make a huge difference to your quality of life. So, with this, it really requires a multidisciplinary approach, because often, one doctor will give you one thing for blood pressure or for your heart, and then your blood pressure is also down, and so it's a matter of really balancing out that and making sure that everyone's on the same page, but also involves our allied health colleagues, so podiatrists, physiotherapists, orthotists, occupational therapists. And really what we want to do is aim for symptom control, maintaining function and improving quality of life. So, as I'm sure you all are very acutely aware of, is that in amyloid there's a considerable impact on your quality of life. And when you talk to patients, these are the major symptoms that really tend to affect people's quality of life. And it's not just physical, they can be mental, emotional, and of course financial. There's also concerns for other family members, and that's often exacerbated in heritable diseases, because there's this sense of guilt of, have I passed this on to somebody else? Have I contributed in some way? And I think this is something that is really often underestimated by doctors, and I think it's really important that we're doing more work in this space, and I think literature is really limited at the moment, but it's gaining a lot of momentum, and I think this is a sort of a space to watch. But I think, in that context, anxiety, depression, and a feeling of isolation is quite common, okay? And so you're not alone in those feelings if you are feeling that way. In regards to nerve pain and sensory symptoms, so often, what people want to know about is the nerve pain agents. So usually first line, and I'm going to talk about this from an Australian perspective. I'm not certain exactly what you can get here, so you can talk to me afterwards if you can't get some of these medications. So usually I'd use pregabalin or gabapentin as a first line. Usually with these medications we start at low doses and you slowly build it up, and that's because all of these medications, they're working on reducing the abnormal firing of your nerves. And because they work on reducing the abnormal firing of your nerves, they also work a little bit centrally. So often people find that if you go up too quickly, you get a lot of cognitive complaints. And you kind of feel a little bit, confused, a bit spaced out, a bit vague, and people don't like that. So often start low, go slow, and build it up. Sometimes these can contribute a little bit to swelling. We need to watch out if you've got a lot of renal impairment. And I think the thing is, if you're on high doses and you come off too quickly, we're recognising more and more that there is a bit of a withdrawal effect that can happen with this. But that shouldn't be something that you worry about in terms of if you're needing it for treatment, but it's only if you come off it too quickly. Second line, and I feel like this is, what I will say actually about first line is if you've got cramps as well, gabapentin would be the one that I go to. And I think, often with a lot of these medications is, can we do two birds with one stone? From a second line, usually I would use these tricyclic antidepressants, so amitriptyline, nortriptyline, again starting low and then building up. I tend to use amitriptyline particularly if people are having trouble sleeping because of nerve pain at night, because it makes you sleepy. You take it at night and it makes you sleepy. And it can have, so it's an old school antidepressant. And so in that context, it does have positive effects on mood if mood is a little bit low. But one thing we need to recognise with these drugs is that they're a little bit of a dirty drug. Okay, so they've got lots of effects on different neurotransmitters in our body. And in that context, you can get a bit of dry eyes, a bit of dry mouth, some gastrointestinal impairment, and usually that goes away with time. So once your body gets used to it, if you start low and build it up, that tends to go away. But we just need to recognise that that can happen. Again, we need to watch out if you've got a lot of cardiac involvement, tachycardia can happen, and again, cognitive complaints as well. A newer medication is a medication called Duloxetine, also known as Cymbalta. So that's had very, very positive effects in diabetic neuropathy. And what you'll know about diabetic neuropathy is it's probably the closest thing that we've got to amyloid-associated neuropathy. It's very, very similar. Usually small-fibre neuropathy progressing to a large-fibre neuropathy. And so in that way, duloxetine can be quite helpful, 30 milligrams daily and increasing up to 60, and it's also an antidepressant, so it can also be helpful if your mood's down a little bit as well. There are lots and lots of other options which I won't go into as much, but if there is a lot of topical pain sensitivity. Sometimes we can actually use, particularly in the hands, for example, or the feet, you can use local anaesthetic ointments. A derivative of chili can actually be quite helpful in sort of desensitizing the hands. And then there are also compounded topical groups, which are a combination of ketamine, gabapentin, amitriptyline, all sorts of different drugs that can actually be useful as a topical, especially if there's a patch. It's not so good if it's all over your body, but if there's a patch that's particularly uncomfortable, that can be helpful. I know somebody else is going to be talking about cannabis, so I won't talk too much about that. And what I will say is that opioids generally aren't that helpful for nerve pain because they don't dampen down the hyperexcitable firing. But they are good for bony pain and other musculoskeletal pains from that perspective. So it wouldn't be a first line that I would think about in nerve involvement. The other thing that can be helpful in neuropathic pain are supplements. So when I say supplements, usually the most important thing is making certain that your nerves are in the best position. So we want to try and limit diabetes. We want to make certain that you have enough other vitamins that are important for nerve health, like B12. So certainly making certain that your B12 is sufficient, I think, is an important thing to do in all people with nerve involvement. But massage, physiotherapy, acupuncture, meditation can all be helpful. And in some people, transcutaneous electrical nerve stimulation can be helpful. So often women who are pregnant can use this sort of TENS, and often it's a patch that gets put on your skin, as shown here, to give you a little electrical stimuli into the nerves, and sometimes that can be helpful in some people. There are all things that you can do. All these complementary therapies is as long as it's not causing you financial distress by trying to go down these pathways, you can do. Some people get benefits, some people don't. But it's a relative evidence-free zone. And the other thing to say is regular podiatry and nail care is really, really important. So if you can't feel your feet, then if you get a cut on your feet, then you're prone to infections and things of the sort. And so actually getting a podiatrist to have a look at your feet regularly at a high-risk foot clinic, for example, and take care of your nails is really, really important to prevent further complications. In terms of weakness, physiotherapists and occupational therapists are really important. So they can give you compensatory techniques so that you can participate in your regular day-to-day life. They can help you with safety by giving you sort of advice about what orthotics you may need. They can provide assistive devices, say for your upper hands, if you're having trouble opening jars and things of the sort because the sensation in your hand's not there. They can provide you with extra things to help. They can help with fatigue management, and they can guide exercise and stretching. And often if you've got weakness of your feet so that you are not lifting your feet properly, orthotics can be helpful, such as these. So there are hard versions, such as ankle-foot orthoses, but there are also soft versions that you can buy on the web called foot-ups that can just help you with your foot clearance, and that can be quite helpful. In terms of cramps, I get asked about this an awful lot. Simple things, hot baths, stretching before you go to bed, massage, making certain within the benefit, within the relative requirements of your heart, making certain the hydration and your electrolyte levels are manageable. Magnesium supplements can be good. Often you need to have quite high doses, and so in that context, that can worsen diarrhea. So usually we say go up to the point that you get diarrhea and then pull back. But if you've got a lot of autonomic dysfunction with a lot of diarrhea, that can be a little bit tricky. We used to use quinine, but it's not so much available anymore, and it can worsen arrhythmia. But certainly tonic water with quinine in it can be quite helpful for cramps. Gabapentin can be useful, and we tend to say if you get nocturnal cramps, having a larger dose at night time. And then, interestingly, pickle juice can actually be quite helpful. There's actually been a randomised trial of pickle juice using pickle juice at a milligram per kilogram before you go to bed at night. Sometimes people find that's better than just water alone. We don't know exactly how it works. We think it's an electrolyte-associated effect, but certainly I've got lots of patients that swear by it. Give it a try. So, exercise. We've been hearing a lot about exercise. Exercise helps your balance. It helps cardiovascular function and fluid in order to get it reabsorbed. It helps your muscle mass. It helps mood, and then recently we've actually shown that it does help nerve function. So this is a skin biopsy sample with those little small fibres that we can see, and this is a person with amyloid actually who has no little small fibres in the skin. And with exercise over a year, we can see that actually this, which is called epithermal nerve fibre density, which is what these are, they do a sample of this and they count how many nerve fibres are in it, can actually increase over a year. Now, this doesn't necessarily mean that you get back all of your sensation. I'm not saying that it's the panacea to all of the other things, but it does just help your general function, and it can help to really encourage those nerves to keep on being active. We aim for 30 minutes, 5 days a week. I'm not saying start with that, but build up slowly and see if you can get to that level. And that could be walking, but if walking's too uncomfortable, hydrotherapy or swimming can be quite helpful, or even a recumbent bike, especially if your feet are quite painful, can be quite helpful as well. In terms of dizziness, so like we've talked about previously, we need to rationalise those blood pressure lowering medications. And that's not only the cardiac meds, but things like Viagra, Cialis can contribute. Medications for prostate can also contribute. So think about what the blood pressure medications or what medications that can contribute to blood pressure are having an effect. And then I guess there are simple conservative measures. So if your heart allows adequate hydration and salt, slow rising from a lying or seated position, elevating your bed. So if you elevate your bed, it actually gets your muscles working. So your muscles work to push back up the fluid, and so that can just help to maintain that tone within your blood vessels. And pumping your muscles, so standing in lines, what we see is that if you cross your legs like this, that actually pushes the blood flow up. And you can see that, that's what's happening here at that time naught. That's actually a representation of blood pressure going up with that manoeuvre. Similarly, pumping your muscles at the same time, or even taking a little folding chair, usually the lower is better, is what this here is showing, can actually all increase your blood pressure up a little bit further. We can also use compression garments, so stockings, and generally the higher the better. Or abdominal binders can be helpful, but they can be poorly tolerated, and often if you've got a lot of neuropathic pain, sometimes it's hard to have something that compressive on your skin. The other thing is sometimes people get what we call postprandial hypertension, and that's basically after you eat, you can get low blood pressure. So in that context, we say to avoid large volume meals, avoid meals that are rich in carbohydrates, and avoid alcohol with meals. So instead have multiple small meals, low in carbohydrate, but of course we want to make certain your weight stays on. And caffeine after meals can be helpful because it actually constricts the blood vessels that go to your gut, and therefore you get more blood going everywhere else, although it can contribute to diarrhea. So in terms of postural hypertension, it really depends on what other organs are involved. So midodrine is our usual go-to, low dose, increasing up slowly. We can use fludrocortisone, however we tend to use less of this because it is a steroid, and as you've been hearing earlier, steroids can contribute to swelling and things of the sort, and so we tend to use it less. And if you get a lot of that postprandial hypertension, sometimes we use a medication called octreotide, and that's really to constrict these blood vessels and get the blood back out to your peripheries. With these medications though, we need to really be careful that when you lie down flat, that your blood pressure doesn't go too high. Okay, because sometimes what can happen is that your blood pressure is really low in its boots when you're standing up, but when you lie down it can get too high, and that can put you at risk of stroke, whether or not that is bleeding into the brain or whether or not it is a clotting stroke. And so things that we can do if you do have supine hypertension, you can have a head-up tilt also can help from that perspective. No nighttime doses of these medications, and actually eating prior to bed can be helpful because we use the fact that the blood goes away to these peripheral, to your gut as a bit of a benefit. But really, with all these medications, one needs to really talk with all of your different players to make certain that everyone's on the same page. I'm not going to talk too much about the digestive tract because Ola's going to be talking about that, but artificial salivas can be helpful, medicating eye drops can be helpful for your eyes, constipation, fluid, exercise, fibre, positioning, so actually having your knees up can be really helpful just in terms of getting you in the right ergonomic position, and then medications for your bowels. For diarrhea, we want to make certain that one, you replace losses so that if you're having constant diarrhea that you've got enough fluid for your blood pressure. Lower fat, higher fibre diets can be useful. Sometimes if you've got really bad constipation, you can get hard stools. That means that you get overflow of liquid. And so we need to make certain that before you start treating your constipation with things that bulk you up, that you make certain that there is no overflow of liquid stools. And then we can use things like gastrostop, codeine can be very helpful, bile salts, again octreotide, and then occasionally actually ondansetron if you've got a lot of nausea, so it's an anti-nausea medication, can also be helpful. Gastroparesis, or that feeling of early fullness and bloating, frequent small volume meals, low fat, low insoluble fibre, no carbonated drinks. We can use medications that are what we call prokinetic antiemetics, so they're medications that cause your gut to move along, can be really helpful, and you take them before meals. We've got to recognise that ondansetron, which is a very potent anti-nausea medication, actually slows down your gut. So if you've got this sort of type of early fullness and nausea, that's not the sort of anti-nausea medication that you want. And then we want to make certain that you maintain your weight, because that's really important for your long-term prognosis. So make certain you see a dietitian and get advice about supplementation if you need to. Bladder and genitals, so avoid drinking in the evening and night, especially caffeinated beverages. Sometimes we can use a medication called desmopressin if it's very severe. Urinary retention, there are some medications such as anticholinergics and alpha blockers, so things that sort of are often used in the context of benign prostatic hypertrophy, so large prostates, but often these drop your blood pressure, so it's important to make certain that that's not causing a flow-on effect. Occasionally, if you're getting really big bladder and you're not able to void effectively, sometimes we actually need to put in a catheter in order to make certain that you're not getting too much retention, and that can be intermittent or indwelling. So there all the time, or you can do it as you need to. So in terms of erectile dysfunction, lots of medications have sexual side effects, and often antidepressants and nerve medications can be. So sometimes the medications that you need for your neuropathic pain can sometimes have flow-on effects to libido and things of the sort. But beta blockers and diuretics can also have an effect. It's also affected by stress and mood. So often we'll try things like Viagra and Cialis, recognising that it does lower your blood pressure, so making certain that your blood pressure is okay, and also that you can't have it if you need nitrates. But there are also other options like injections, pumps and surgical measures, but that requires a referral to a sexual health clinic, and vaginal lubricants can also be helpful. Last and sweating. So usually this is not so much of an issue for our patients. I think there are bigger fish to fry, but in some people they can have really, really profound sweating effects. So anhydrosis is reduced sweating, so things that can be useful are moisturiser. And I think it's really important that, on really hot days, you need to really avoid exposure and make certain that you're in a cooler area, because you can't actually sweat to release your heat. So that's really important, and then that exacerbates blood pressure and cardiac effects and things of the sort. With increased sweating, we can use astringents and aluminium-containing perspirants, not necessarily just in your underarms, but on your skin in general. You can do topical anticholinergic creams. We don't like to give oral if we can, because of effects on dropping your blood pressure again. But Botox can be helpful under the arms, palms and face if there is a particular patch that's particularly sweaty. If it's really generalised, sometimes we can use really low-dose anticholinergics or even amitriptyline, so we can do it 2 birds, 1 stone with the neuropathic pain medications. And there are surgical things, but usually we try and avoid that in this circumstance. But you need to recognise that, especially with, say, Botox and these surgical procedures, is that you can get something that we call compensatory hyperhidrosis. So it just moves from one place to another. So I'm not going to talk too much about this because I think we've heard a lot about it so far, except to say that certainly, this is a really great results that we've seen in terms of the Apollo for patisiran and the inotersen results in terms of improvement or stabilisation. What's important to say is that this MNIS7 and this MNIS7 are not the same, so they're not directly comparable. And so we're not certainly certain that patisiran is a lot better than the inotersen in that context, but certainly there are slightly less side effects with the patisiran, which is why we have been using a lot of this at the time, and also we've been able to get the trials. But certainly there is improvements in terms of functional outcomes, in terms of walking, sensation, neurophysiology and autonomic dysfunction in both, as well as quality of life. And so certainly it's what we're trying to get most of our TTR patients onto if we can. Easier said than done though. And I guess the other thing to say, and this may kind of touch a little bit on a question that happened earlier, is that, while I won't talk about the regimens or the goal, is that sometimes chemotherapy can cause neuropathy. And that can cause a bit of confusion as to whether something's getting worse. Is it getting worse because of the chemotherapy, or is it because the actual neuropathy and the underlying process is not being controlled? So the history of the timing of the worsening and progression is the most important thing that we can do to really get to the bottom of this. And so often you'll go to a neurologist and they'll be really pestering you for information about when it happened and why and how has it changed now once you've stopped it, what's really the evolution of things. And so don't be annoyed at them for doing that. They're really trying to get to the bottom of exactly what is the contributor. Most chemotherapy causes what we call that axonal neuropathy, so affecting the electrical wire. But Velcade can cause a significant demyelinating neuropathy. And so often it's something that we do see in this circumstance, and we often have to dose reduce in that context and give it in a slightly different way. 2/3 of people improve with cessation after about a year, and 1/3 remain with some neuropathy, but you can continue to improve over the course of years. And in that term, sort of nerve prognosis is really dependent on severity and duration of the neuropathy. Nerves can regenerate, but it's slow, so they tend to grow back at a rate of about 1 millimetre a day in the best possible circumstances. So that's without ongoing effects that can cause irritation on the nerves. Often if there's profound wasting, then sometimes the nerves won't grow back in the same way. And it's important to know that nerve hyperinsensitivity can worsen when the nerves are improving, but that nerve conduction studies are often a bit insensitive to that change. And so we're actually currently looking at biomarkers in order to monitor and see if there is ongoing nerve irritation in that context. And that's sort of the research that we're doing at the moment. So amyloid predominantly affects the large, small and autonomic nerves. It results in sensory changes, pain, weakness and a range of autonomic symptoms. We want to treat that underlying disease, but there's lots that we can do to improve your symptoms, and it's often a bit of trial and error to work out the right combination with you and to make certain that we're not doing too much pushing and pulling. So know your symptoms so that you can feel empowered to discuss it with your doctor and to be able to say, could we try this, could we try that? But that we really need to have coordinated care amongst patients, but also the different specialties involved to make certain that you're not, pushing and one person's pulling at the same time. Thank you.